Well, thank you for joining us today. So we felt it was time to discuss where we are with COVID now, 5 months later, for those of us in Missouri, and even longer for others around the country and the world. Joining us today to bring us the latest on what we now know on COVID-19, we have Doctors Scott Jamieson. His specialty is in internal medicine and a specialty in functional medicine. Scott, can you say hello to everyone?
Good afternoon.
Thanks. Varsha Ratode, internal medicine and specialties in rheumatology and functional medicine. Varsha?
Hello, everybody. Welcome to the webinars. We love having you here.
Great. And Lauren Del Farra, she's our CEO of Palm in internal medicine and specialty in cardiology. Lauren?
Hi, everyone. Sita, thank you so much for having me today.
Absolutely. So I'm Sita. My specialties are in pediatrics, neurology, and headache medicine. So I thought we could start with some background and a little bit of a frame of reference. I think it's amazing to think back and know that our first laboratory confirmed case of SARS-CoV-2 infection in the United States was in January 20th of 2020. And in the United States, we've passed 5 million cases and over 165,000 deaths. So I know historically we've always focused on case counts and trends of total number of cases, which is an important part of the whole picture. But given the sheer amount of asymptomatic spread and the inconsistency in test availability, we have really turned to analyzing trends in death data as well. And this helps us understand where we're headed in this pandemic and how each state or country is even doing. The death rate, or what we also call as the case fatality rate, helps us understand what the true impact on our public health system is with COVID-19. And it's hard because we're always being overwhelmed with the amount of information and data from so many sources, the news, social media, and other outlets of information. And while it's really important to be informed, I just encourage you not to allow the sheer amount of information to impact your overall sense of hope and resiliency during this unprecedented times. And, you know, after 5 or 6 months, we know that our mental health is impacted. And despite the needs to continually socially distance, we have to remember our connections with others, our loved ones, and our friends in our community. We have to stay connected, albeit in a different way. So I encourage you to look within yourself to find meaning and purpose in your day-to-day as well as globally in your life. And I want to remind everyone, while, you know, health and science field is dealing with something new, and we have to use science to help us make predictions and give us best guidance to how to diagnose, manage, and treat individuals with something new like COVID. So when the providers at Palm decided to do another webinar on COVID, we thought, you know, what are the most commonly asked questions that we get day to day from our members and our patients? We ask ourselves, do we have really new information to share? Do we have better ideas of what we should be doing? I hope that you'll find today's discussion fruitful and informative. And as a reminder, you can submit your questions on the chat feature on the computer. And if we have time and we're able to, we'll answer those questions. So let's go ahead and get started. And I'm going to start with Varsha. Can you help us kind of paint the picture of what are the typical symptoms of COVID? What's that spectrum? And really address that asymptomatic person. And, you know, there's a lot of information about that, and we didn't really know whether that was true or not. So can you give us a little bit of more insight on that asymptomatic individual as well?
Surely. First, in terms of symptoms, almost any symptom is possible. So I'd like to divide this up into areas. So first, in the 5 million that we have tested, 40% are felt to be asymptomatic. But remember, this is only the tested population, so the predicted asymptomatic cases is much higher. Then the next category I'd like to consider is mild to moderate illness. This is what we see at Palm, that is people who are taken care of at home. So the 5 most common symptoms that are seen in patients who have COVID or people who have COVID at home are: number 1, headaches; 2 is loss of smell; 3 is nasal obstruction, kind of feeling full in your nose; cough and this general malaise and weakness. Remember, fever didn't come in here, so these crossed 60 to 70%. Other common symptoms, which are higher than 50% of the population have, are body aches, runny nose, altered taste. Many of them have had altered taste, and sore throat. Fevers in this population was only in 45%. So that was quite incredible to know, because everybody's looking for fevers. We test for fevers, right? This is quite different when a patient has to get into the hospital or they get really sick. Symptoms, the 5 most common symptoms at admission were: number 1, fever. Almost 100% had fevers over 100, shortness of breath. They had cough, fatigue, and a lot of mental confusion, because when you don't have oxygen, you get confused. Then the next category is all the complications associated with COVID. They have their own symptom list. So in the hospital, we see something called ARDS, acute respiratory distress syndrome. And that's because the blood vessels get infected and start leaking into the lungs. And so those are people that require ventilator treatment and dexamethasone. Myocarditis is extremely common. It's worse in hospitalized patients, and that's where the drug Plaquenil and azithromycin were found to cause even more problems. Acute renal failure, short term, during the crisis. Encephalopathy, that means infection of the brain, is also extremely common. Coagulopathy, that means the formation of clots all over the body, was also seen a lot. And then very unique in kids is a inflammatory multi-system disease, which was similar. We can't call it Kawasaki's, but it's very similar to Kawasaki's disease. So those were those symptoms. Sita, to come back to your question, is it what do we know about these asymptomatic, and is it truly a problem? At first, we thought, well, asymptomatic is asymptomatic. That's well and good. Well, number 1, asymptomatic people can be carriers. Number 2, we're finding that 2 months out of their asymptomatic period, that in one small study from Germany, 78% had evidence of myocarditis. So scarring of the heart, rhythm problems, palpitations. And then 50% in an even smaller study out of one of the ships showed that they had lung disease on CT scan. So while we think we are asymptomatic, we're internally taking major hits. So the best way is to prevent it. And the second best way, if you can't prevent it, is to maintain good health so you can combat it.
Farsha, thank you so much. And I think that what's really important there is that these symptoms can be subtle or non-existent, but the long-term impact on your body is really astounding. And with these studies that we're seeing and following these cohorts of individuals who were asymptomatic, who are now actually showing symptoms. So I think that's really important. And knowing that we have asymptomatic individuals who are mild, Lauren, I really would love to hear from you. What are the ways that we should still be preventing COVID? I know we heard a lot about it. You know, is there anything new? And then also, I'd really like to hit, since you can speak to this, what are we really doing at Palm to help with the prevention of COVID as well?
Sita, what we can say about prevention in general is that the principles we've been speaking about for the last 5 months are truly effective. So really good hand washing, really spending time to, wash your hands with warm water and soap, wearing a mask, keeping socially distant when you are out in public. All these things actually work. We've seen a lot of cases where patients have been positive and they've followed these principles in their workplace, for example, and coworkers have not become infected with coronavirus. So the basic principles work. Beyond that, we are really promoting, maintaining good health and maintaining a healthy immune system, which oftentimes can be promoted by nutraceutical supplements. And I think it's important to understand the mechanism of action of the supplements in terms of understanding why we would recommend taking them. So the basic vitamins that we often recommend taking are vitamin C, vitamin D, zinc, and NAC. And the reason that we promote those specific supplements are based on their mechanism of action. So for example, we know that zinc does a good job of inhibiting viral replication. So if you already have that supplement on board in appropriate quantities, and you are infected with the coronavirus, zinc can help inhibit the replication of that virus. And we know in the common cold that it does a good job of reducing both the severity and the duration of symptoms. For example, vitamin C and NAC are both great antioxidants. So we know one of the complications of coronavirus, whether you're asymptomatic or symptomatic, comes from this inflammatory response that happens, whether that's inflammation in your heart, such as myocarditis, as Varsha was saying, or some complications, or inflammation in your lungs and acute respiratory distress syndrome. We need to help support the healthy immune system and inflammatory response. And both vitamin C and NAC are very strong antioxidants and free radical scavengers. And then vitamin D, in addition to having both anti-inflammatory properties and immune boosting properties, has great scientific evidence in terms of supporting respiratory health. And we know that, for example, in children with vitamin D deficiency, they're more prone to respiratory infections. So these basic nutraceuticals that we don't often get proper quantities of in our diet are great ways to create the foundation for a healthy immune system, and we strongly recommend them. To answer your question about what we're doing at POM, we are following all the general precautionary measures of, deeply disinfecting the center throughout the day, high touch surfaces. We also have 2 ultraviolet robots that do roam POM at night and sanitize all of our rooms, helping to kill viruses and bacteria. And we also have ultraviolet wands that we use over high touch surfaces as well, like computers and cell phones and so forth. So, and we're keeping our employees healthy most of all, helping support them also with vitamins, minerals, healthy food access, and really making sure that if anyone is exposed to someone with COVID, that we're keeping them out of POM. And likewise, that if we have any members or employees that have had any exposures or positive cases, that we're contacting everyone so we can participate in our responsibility to help quarantine and isolate cases.
Thanks, Lauren. I think it's a really good just reminder after 5 or 6 months of COVID. I think early on, everyone was doing a lot. There's a lot of hypervigilance around prevention. And over the course of the months, I know that as we've been kind of going back to work, going back to school now, thinking about prevention again and reminding everyone about masks and hand washing and supplements, I think is a really good reminder. And Scott, I kind of want to turn to you because although we want to be promoting a lot of prevention, there's an idea that everyone's going to get infected. So why worry about prevention? So can you speak a little bit to that? Why are we so worried about still preventing COVID?
Well, I think as we look at the early phases of this crisis and as it evolved, it's really about making sure we decrease the hospital burden and don't overload the system. So if we can kind of keep the infection rate, which is going to continue to spread, if we can keep it flat and manageable, we're not going to overload the very finite resources that we have with hospital care and ventilator care and bed space, but also even the things that we've seen crisis with, like getting access to masks and other PPEs. And so if we can keep these curves under control, we have an ability to match the needs of these items, both hospital and PPE, to the ongoing needs of the community. And we've seen in states where that's not happened well, that the ICUs are overloaded, the ERs are overloaded, there are no masks. And so we really want to work hard to try to prevent that. I think a more hopeful idea is that by spreading out what may be inevitable infections, as we've all seen through this webinar and will continue to see going forward, research is very aggressively on an international basis evolving. We hope that new treatments, new preventive measures, new therapies are going to come into play. And so the thought is if you get sick 3 months from now versus now, we may have potentially better options for how to address that. And we're still learning more about this virus and about its effect, as we've already mentioned a couple of times already, and we'll talk a little further. This whole evolving concept of post-COVID syndrome or symptoms, we're still learning. And so the more we can slow down the infection rate, the more we learn, the more we know how to follow people, address people, and help them as they go forward into what's going to be a difficult winter and year ahead.
Yeah, and I think, Scott, when we talk about the prevention, you know, reminding ourselves that we're part of a huge community, you know, and reminding ourselves that we're helping not only ourselves, but helping everyone in the community around us. And so I think that those are all really good points, and reminding us of that. So you've spoken to us previously about treatment and what should we be doing in those early days. What do we know now about those first few days when somebody might still be at home and hopefully stay home? What can we be doing to help them not have to go to the hospital? And what should they be monitoring at home in those days?
Yeah, great question. I think it is, one, being aware of what is your basic health, you know, what are your risk factors, and knowing, kind of going into an early diagnosis, where you are medically. I think from a monitoring point of view, if you have access to a pulse ox, that is a very critical tool in monitoring how things are potentially evolving to what is the most critical outcome, which is respiratory distress or failure. Keeping track of your fever, are you getting short of breath? Are you getting weaker? Are you having GI symptoms that may lead to dehydration? And really sort of that sense of, are you worse today than yesterday? Are you, you know, on a progressive turn of worsening? Those are sort of the early things that we want to know when we talk to people on the phone and follow up the next day. You know, is there this progression? I think from a really critical thing, as we've learned, again, looking at the respiratory effects, deep breathing, keeping the lungs hyperinflated. We talk about, you know, getting up, moving around, not laying in bed where the posterior aspect of the lungs get flattened out. And so getting up, moving around, deep breathing in an upright position, bending over on all fours face down, taking big deep breaths to try to keep the lungs very inflated. And again, as we've said several times, this treatment with antioxidants and vitamins to keep the immune system up, we really feel that these are important things that, particularly in that early onset of an infection, and again, I would argue even in an asymptomatic positive patient, really aggressively supplementing the nutritional support of the immune system, reducing inflammation, are critical aspects of trying to prevent an illness from going from a mild to moderate to something that could potentially require hospitalization.
Thanks. And I want to commend you and Dr. Rateau and Dr. Williams in getting together and really helping to inform us of now what should we be truly treating from a supplement standpoint, in prevention, in treatment, and then kind of later on. And so, or if you've been exposed. And so I know that you guys came up with some recommendations on these COVID treatment kits and these COVID supplement kits for prevention. And I know that that's been really helpful for our community at large. So thank you for doing that, all of you guys. I'm going to turn to Varsha, because you also related to treatment, since we are on that topic. On a previous webinar, we spoke really about those anti-malarials, antivirals, even azithromycin. Can you tell us what we know now about treatment for COVID using those pharmaceuticals? And are we still using them, or have we turned to other things? Where are we with different trials?
Sure, I'll keep this really short. There are no antiviral treatments. So if you're not in the hospital, there is no treatment for COVID-19. If you're in the hospital admitted, then the government, because of some very sick individuals, has passed something called CTAP, and CTAP refers to the Coronavirus Treatment Acceleration Program, where they allowed certain drugs to be administered in trial basis. So the two that are most well studied are remdesivir, an antiviral, which is given intravenously. So we at Palm, of course, cannot give it. And then dexamethasone, if oxygen requirements are high or you need to be on a ventilator, because it has been shown that they can prevent long-term ventilator use and also deaths. So those two are really good. There's some others that are studied, but nothing is perfect. and I mean, I don't want to belabor those since really it's all part of hospital medicine.
Thanks, Varsha. So can you just speak one moment about convalescent plasma and some of the biologics?
Yes, convalescent plasma is plasma from patients that have recovered. And so it's felt that if you give them plasma exchange, then they would be able to recover. There have been some case reports showing, yes, it's helpful, but the studies have not been really well done. So it is not commonly used. And also it's felt that these neutralizing antibodies are different in different people, and we don't have a way to study it really effectively. And for the second, the biologics, the best studied one was Actemra, an IL-6 antibody, but there are others that are also being studied, and they decrease, say, by 3 to 4 days, and also decrease the chance of death.
Thanks. I think that although they're not widely used, I think that's a lot of people are asking questions about those, so I appreciate you addressing those as well.
Yeah.
Both you and Scott, I'm going to pose this question to you, Scott, about kind of that post-COVID syndrome. And we have seen that not only during the time of COVID, we're seeing symptoms that develop, but some of these symptoms are really going for a long time. And, even weeks or months later. Varsha had mentioned this myocarditis. What is that spectrum that we're seeing in our own patients, and what should we be looking out for, and what can we really do about it?
Yeah, I think this is an interesting topic that continues to evolve. I mean, we're only 5 or so months into this, and so every day there's a new article or a new descriptor coming out about this so-called long hauler post-COVID patient. I think the one that I see most commonly is fatigue, and it's apparently very profound fatigue, very much like what we see in some other post-viral chronic fatigue syndromes. And the numbers are alarmingly high in many of these patients. 20 and 30% of patients are experiencing fatigue. And as Varsha pointed out earlier, sometimes it's not even the most sick patients who get this post-COVID syndrome or symptom. It can sometimes be people who are very mildly affected. And so this is an alarming point for us in that we're continuing to learn, and it's something we're going to have to continue to be aware of, educate people, and monitor. Beyond the fatigue, the next couple of areas that are coming up is we're seeing, and this has been reported in both Boston and New York, more neuropsychiatric symptoms. And what we mean by that are people who may have had some mild underlying anxiety, depression, who in this post-infectious period have marked exacerbations of altered thinking or mood disorders. And again, we think this is probably related to this mechanism of action of inflammation and alteration perhaps of the blood-brain barrier from inflammation, sort of getting back to the importance of this, correcting this or trying to offset this with our antioxidant therapies. The third common area, as Varsha's already pointed out, so I won't go into it much, but it's very disturbing, is this myocarditis, this inflammation of the heart muscle. And this can present with someone who's had COVID, and then they're weak and tired, and they just don't recover the way they should. They may have exertional shortness of breath going up a flight of stairs, maybe not able to get back into their exercise program the way they think they should. And this is when it needs to come to our attention. We need to think about, do we need to do more formal studies? Do we need to look at echocardiogram and again, address this? The truth is we don't know where this is going to go. We're still very early on. We don't know, are these things that are going to self-remedy over time? Are they going to develop into longer, more chronic, debilitating issues? Again, I think this post-COVID syndrome really does further emphasize the importance of these early treatments with these antioxidant, immune-boosting supplements and nutritional support for all patients who are COVID positive.
Thanks. And I think it was good to, spend the first half an hour of our webinar really on what are those symptoms, what are we doing for treatment, really understanding that again, and what does that spectrum look like for those individuals who are infected. I think it will be good now to turn really to the quarantine, because that's what, you know, what should you do? Should we be isolating when we're exposed to somebody with COVID-19? And I think that the majority of the phone calls that we get as paramedical providers is, what do you do in these different circumstances? So Lauren, I know that you and I field a lot of these questions, and would love to play a little bit of what if you get a call, because I think that these are very common questions, and I think it's really good to be informed about how you should be quarantining. So are you ready?
I'm ready, Sita. It sounds like a game show.
All right. So I want to start with the most basic. So I have symptoms of COVID and I haven't gotten testing yet. Should I be quarantining? What should I be doing?
So if you have symptoms of COVID, you should definitely be getting tested. It's important to know what you're dealing with in that case. And, you know, we do have various levels of inventory right now for rapid tests in the community, but those fluctuate. If not, the send out labs are taking anywhere between 5 and 10 days. So in that interim period of waiting for that test result to come back, if you do have classic symptoms of COVID, we are recommending people to get tested and to self-quarantine while they're waiting.
So let's say I get turned positive. How long should I wait before I go back to work or back to school?
The guidelines are recommending that, assuming you are fever-free and your symptoms are improving, you can return back to work or go back to school about 10 days from the onset of your symptoms.
Great. And so we've been getting, and now that we know that there's a lot of asymptomatic patients that are traveling, and so they need to get tested, or they need to go to school and college and they're getting tested and they're coming back positive and they have no symptoms. How long do they have to quarantine?
That's a great question. We're definitely seeing an increase of asymptomatic positive tests as kids are returning to college and getting screened before they can enter the dorm rooms. So the guidelines recommend 10 days from the positive test result for the duration of the quarantine.
Great. And then another common question we get is, I'm a parent. I have a 7-year-old, 8-year-old who's tested positive. What do I do? Can I go to work?
So that's a great question. You cannot go to work. You would be considered a positive exposure. And whether or not you become infected and actually develop COVID or you don't, you do need to quarantine. It's tricky because with a 7-year-old, you know, that's difficult to isolate that child. So you really will have continuous exposure to them. So the guidelines recommend that once they finish their 10-day quarantine, you would need to quarantine an additional 14 days from the end of their release date. So if they, for example, were symptomatic, 10 days from that start date would start your 14-day clock. So it does unfortunately put a lot of people out of work and out of commission for a fairly long duration of time. However, if you had that same scenario and your child was 17 versus 7, and you were able to self-isolate from them, or they're able to self-isolate, and you were able to then start a quarantine immediately kind of on their test positive date, your clock would start 14 days from that point in time for your quarantine.
Great. Another question. I just got an email and my coworker at work just tested positive. What do I need to do? Most
frequently asked question. So in that case, you really need to determine if you were true positive exposure, if you had a true positive exposure. And what we have to look at on that level are a few factors. One, when were you in contact with that person? And when did they start having symptoms? So for example, if you were in contact with them the day before their test turned positive, you're within that positive exposure window. If you were within contact with them 2 days before, you were in that positive exposure window. If you were in contact with them 3 days before their symptoms started, you're starting to get in the gray zone of a positive exposure. So the first question is, are you in the window of risk? The second question is, were you in close contact with that person, working closely less than 6 feet apart, and for duration of over 15 minutes. So you need to look at how close in proximity you were to them, how long were you in close proximity, and were you in close proximity to them during their kind of high risk viral shedding period. And if we determine that you are indeed a true positive exposure, then you do need to quarantine for 14 days. A lot of people ask, even if I get a test result and it's negative, do I still need to quarantine? And the answer is yes. If you're true positive, because it can take a long time for that virus it can take up to 14 days for you to present symptoms and have the viral incubation period, the guidelines do recommend that you quarantine for 14 days.
Great, thank you. And I think that some of those are pretty clear. And one of the things to remind ourselves is it's not for you to remember all these, that you can always contact your medical health professional. I know that at Palm, we are getting these calls all the time, and we're here to help anyone who's a part of our practice to help them sort through whether they should be quarantining or not. Yeah. And I want to give you one last example, because this is also just a little bit more in that gray zone that doesn't have that clear, like this is what you should be doing. But it's been coming up, especially because we are testing a lot of asymptomatic people that are going to college. So let's say you have somebody that tested positive, they're asymptomatic, they're going off to college, and you were around them 3 days ago, 4 days ago. You know, they're asymptomatic. We have no idea when they got it. What should you do?
That is definitely another frequently asked question, and it really is that gray zone. In those kind of cases, there aren't clear-cut guidelines, so we kind of have to use our best guess or our best risk assessment platform. So for example, if you look at the case you just gave me, you were with someone, 3 to 4 days prior to them testing positive. Technically, you are potentially out of that high risk exposure period, but as you said, they were asymptomatic, so you don't know when their symptoms started. So again, you look at how close of a proximity were you with them? Were you wearing masks? How long were you together with them? And, I think that really comes into play. Are you experiencing symptoms, or, do you live or have close contact with someone who's immunocompromised, or where really passing on that infection close to you would be quite problematic? So what we're recommending people who have concerns and who kind of fall in that gray period where we can't really determine if they're a positive exposure is oftentimes we recommend that about 5 to 7 days from the date of their exposure, they get a test. And if they are negative, then we feel comfortable telling them they wouldn't need to follow that 14-day quarantine. If unfortunately they're positive, then that becomes a different story. But we do recommend that if they're that concerned, or they're living with people who are high risk, immunocompromised, or elderly, and they're worried about passing on that infection if they happen to have gotten it, we recommend they quarantine up until the time they get tested, and then go on from there.
Thanks. I think that those are really helpful. And so thanks for playing our game.
It's fun. Thank you.
It's a constant thing that we've been fielding these questions. Yeah. So Barsha, I'm going to turn to you, and we're going to switch gears and talk about antibodies. And, I would like to start with, do we know whether we can be immune to COVID and get these antibodies, and how long those last? And should we still be getting antibody testing? When is that helpful? And, is there one antibody test that might be better than others? Can you speak to some of those questions related to antibodies and immunity?
Yeah, sure. First, in the case of simple coronaviruses, not COVID-19, it's felt that the antibodies last for about 3 to 6 months. With COVID-19, not much is known, but the best study was coming out of that first January 20th. By May, New York was testing for antibodies, and they found a huge number of patients still had antibodies, right? So we do form antibodies, and we get short-lived antibodies called IgM antibodies, as well as long-lived, or what we call memory antibodies called IgG. So the question is, how long do these last? And it's felt anywhere between 3 months to 2 years. But here's the good news. If your antibodies do disappear, that doesn't mean you are totally, you have to start from scratch all over again. Because your cells, your B cells and T cells, go into hiding. They have memory cells, and those memory cells at the site of the next infection can quickly launch an accelerated response. So that's with antibody testing. In terms of who and where to test for antibodies, that's been quite interesting an experience. So we have been using Vibrant Labs at Palm Health, and those have been quite consistent. And I'm going to give myself as an example. I tested positive in April, mid-April, when we first started testing. And then I went back in July, end of July, and retested and found that I was still positive, but the acute antibodies had disappeared. Right? So I'd be curious now to wait 6 months and to check to see, am I still positive? But again, don't lose hope if you're not positive and if you chose to do this experiment for yourself, because there are many ways that you can mount an immune response. The immune response is quite complicated. It's not as simple as, you just get an antibody. It's about cells, it's about innate immunity, it's about adaptive immunity. In the case of antibodies, of course, we're talking about adaptive immunity. So most of us will have it, I would say, for about between at least 3 to 6 months.
Thanks. And I think that it is important to know that there's not, all of these tests are going to have false negatives, false positives. And it's how do you find that best test? And I think that, the verdict is still out. I know that we've been very happy with the ones that we've been using at Palm. And I think that there's still going to be a lot more that we're going to have to investigate. One question that has come up a lot, and you've kind of touched on it, but I want to say this and ask you this pointedly, which is, can you get infected twice with COVID-19 virus?
It's felt to be very unusual. Most of the early Korean cases, it was really they hadn't got rid of the infection and they were testing RNA in the sample, which is kind of long-lived. The RNA can stay there, but you don't really have an infection. But having said that, nobody knows for sure. And so that brings me to the subject of herd immunity. What is herd immunity? So a certain amount of the population has to be immune for us to develop herd immunity, meaning you don't rapidly spread an infection. For example, in a very active and virulent virus like the measles virus, you need to have 94% of the population to be immune. That's a huge amount of the population to be immune so that you don't spread measles. It's felt that COVID-19 is going to be very, very similar. So waiting for everybody to get infected is not going to be the best case scenario. And Scott will talk to you a little bit about where that vaccine might come into play to develop that herd immunity. Even if it doesn't fully protect you, you're really increasing herd immunity so that the virus doesn't spread.
And Varsha, one more question that came on live by one of our participants that I wanted to touch about that you spoke about related to plasma or convalescent plasma. So the question is if a person is in the hospital that with COVID-19, and can they receive plasma from a COVID relative? So somebody who in their group of family has already had COVID, they want to donate to the individual that's in the hospital. Is that even allowed? How does that work? Or do they have to go to other places like the Red Cross to be able to get that convalescent plasma?
They can't go to the Red Cross. They have to go to places where they do the studies, because remember, this is a CTAP. So they have to go, like, for example, I had a patient who donated her plasma to Barnes, and she was not happy when after a while Barnes said they couldn't use her plasma anymore, even though she had good antibodies. And it's because her antibodies would not neutralize COVID, right? So they study that before they give it. And that's why it's in that CTAP phase. And we couldn't give it in just any hospital. You have to be part of that study.
And I think that's what's important is if I have COVID-19, I'm in the hospital, I can't wait for my family member to get their plasma donated, get it tested to see if it works before it's given to me. Right. And I think that that's really the most important is that the timing is just not practical when you might want to be treated with that convalescent plasma.
That's correct.
So thank you so much for speaking to that. And Varsha had spoken a little bit about this herd immunity and vaccinations. And so Scott, can you tell us where we are with vaccinations and also speak a little bit about the flu vaccine, because I know that's been a common question as well. Since the COVID-19 vaccination isn't ready and available, what can we also say about the flu vaccine?
Yes. So I think, like everything with COVID, the vaccination development and protocol has been sort of Wild West, rapid development, and it usually takes years to develop an effective vaccine. And obviously, we're on a very accelerated protocol for this. There's at least 3 or 4, getting into later stages where we start really looking for efficacy, safety profiles. Russia has reported they have a vaccine. It's been in the news, and I think I'm going to leave it at that. I think we have to be very skeptical of the, how that's being addressed in protocols of safety. This is going to be a slow process. We have to make sure we have a vaccine that is safe and effective. As Varsha just pointed out, not all antibodies are completely neutralizing to the COVID virus. So it's a matter of, is it effective? And then we have to have a certain amount of safety data before we can very comfortably take it out in a broad-based use. So while this is certainly part of our ongoing hope and optimism for dealing with this current situation, I think we still need to sit and be patient. And the only way I know to look when that time comes of should I or should I not take this vaccine is really going to be at that time to really be aware of where the safety, what is the data. I think just because there's a vaccine available, I'm not going to just say, go take it. So it's going to be a very careful evaluation, like everything with COVID, an ongoing evaluation. And we have to be very careful because of how fast these things are being pushed. But the hope is that we will have, a usable, helpful vaccine at some point that is going to help with developing this broader immunity. As Varsha pointed out, to develop herd immunity requires huge numbers of people who are immune positive, and we're just, even with the spread we're getting, we're nowhere near getting close to that. So back to the beginning of this webinar, the personal protective measures and protecting our loved ones by taking these safety measures still is at this point the key to moving forward. With regards to what's around the corner, the flu season is coming, and we're really anticipating what it's going to be like from a clinic point of view with people with fever, chills, and symptoms, trying to decide, is it flu, is it COVID, or perhaps both. And so I think the flu vaccine is always important, particularly for higher risk patients. It's going to be very important this year. The hope is that if we can reduce the impact or the burden of flu through vaccination, that is going to prevent some of the cross comorbidity and perhaps some of the other diagnostic issues for us trying to decide what people are sick with. I think it's going to be very interesting this flu season to see how the season goes with these other protective measures, wearing masks, physically distancing, hand washing, all things that should theoretically reduce the burden of the flu vaccine. At Palm, we're going to have, as we did last year, we are going to have flu vaccines. We'll have flu clinic where we'll be able to come and get vaccinated. And those will be announced as we get closer and get dates available. I do think we're shooting for mid to late September to try to be ahead of the upcoming flu season. And we always use preservative-free flu vaccines. So I think it's something that is reasonably safe in the vaccination concerns.
Thanks, Scott. And just one of the questions that came up in from the participants, and I think you really addressed this, which is it takes a lot for us to develop that herd immunity. Do you know if there's anywhere in the United States that we have seen that herd immunity has happened with COVID-19?
Not that I'm aware of. I did just see an article yesterday that a big study in Great Britain looked, and I mean they looked at all, and they are nowhere near. I mean, the numbers that Varsha mentioned, it's still, it's just, we're nowhere near even obtaining a natural herd immunity.
Yes, Sita, so far no country has developed herd immunity to COVID-19. We might be the first because we have the highest rate of infections.
Yeah.
Well, so as we've been talking about vaccines, we want to also think about kids. And so Lauren, I wanted to ask you the question that we also are getting commonly, which is, should kids be going back to school? What should we be thinking about as kids are going back to school and helping to prevent that spread of COVID-19?
You know, the basic principles of prevention, whether we're talking about preventing cavities in kids or preventing getting infected with the coronavirus, come down to education and practicing good habits. And, you know, kids are learning and looking at their parents as models, looking at their older siblings as models. And so modeling good behavior, you know, is fundamental to helping support your kids in preventing and becoming infected with the coronavirus. Basic principles, as we talked about, really good hand washing, but also trying to get them not to touch their face as much, not to be bringing up those little hands into their mouth and into their nose, which is definitely more challenging the younger the kids are. And then wearing a mask when they're around their friends, and also mask hygiene. So that's another aspect of really, when you're taking off that mask, using two hands, taking it off from the ears, putting it into a Ziploc baggie, you know, folding it in half where the outside remains on the outside. And then when you're putting it back on, taking it again by the ears and placing it back on over your mouth. So practicing good behaviors with your kids, really educating them and modeling that's really the fundamentals of getting them to start then developing those good behaviors. You know, should we be sending kids back to school? That's a deeply personal question that everyone's going to have to face and weigh their own consequences and risk to benefit ratio. And, you know, it depends on so many factors, like, do they have childcare otherwise available to them? Would the effects of social isolation be worse than the effects of the coronavirus? There's so many personal questions. Do they have someone elderly or immunocompromised at home that they need to protect? So, you know, fundamentally, we do need to help support people from all the other types of, you know, terrible consequences that something like a pandemic creates, especially in the way of social isolation and depression and anxiety, and try to get people to adapt as much as possible to being proactive, but also living their life. And so for sure, anybody who needs to send their kids to school and wants to send their kids to school, I believe absolutely should. I think it's really just about trying to enforce and promote good habits as much as possible. Again, in kids can take supplements. Vitamin D, we already talked about. We know in children, you know, helps promote bone growth, helps promote the strength of muscles and ligaments and respiratory health. So that would be, you know, a supplement, especially in children, that I would definitely make sure that children are having adequate levels of vitamin D.
Thanks. And so let's say you have your kids that are going to school, which is, I agree with you completely, but you have somebody who has cancer at home, or you are taking care of your elderly parent. And so now you are potentially increasing that risk. What would you say to that household in helping protect that individual that's at high risk for developing complications of COVID-19?
You know, those are really challenging circumstances. And again, it's unfortunately a lot of the practices that will help prevent the spread of the virus, you know, lead to potential consequences of people feeling socially disconnected and isolated, which has its own complications. But doing things like, you know, not eating necessarily together at the same time, making sure that if you are in contact within the household that you're wearing a mask, both the child and the elderly person and the adult, whenever you're in close proximity, frequently disinfecting high touch surfaces, but also remembering to spend time together and not just isolate everybody in the house from each other, where you're just going to have other ramifications of depression and anxiety. So taking walks together outside, you know, maybe you're keeping a little bit farther apart than you normally would, but still engaging in activities where you're doing things together just safely.
Thank you.
Yeah.
So Varsha, I wanted to ask you a question that comes up commonly, which is, what are the risks for individuals who are pregnant, the women who are pregnant, and are we seeing transmission to the babies when they're born? What should we be telling parents who are expecting?
First, I have to tell you that I will answer this question saying that I'm not a gynecologist, but I've done my research. Right? So first, a patient who's pregnant doesn't have a higher risk of getting COVID-19 than you and I do if they use all the proper precautions. If they do get COVID, then they're more likely to have more serious complications if they have comorbidities, right? So, and the most common time that they do get into comorbidities is in the 3rd trimester of their pregnancy. So in terms of vertical transmission, thank God this is not a Zika virus. You know, there's not been morbidity that has been shown, even in the 2 cases in Italy where the child was shown to have received vertical transmission. That means when the baby was born, it already had IgM antibodies, which are the acute antibodies, which cannot be transferred through the placenta. So it can happen, but it's very rare for vertical transmission. And if it does happen, it's going to be for those patients who get infected at in the end of the 3rd trimester.
Thank you, Varsha. And I think that kind of wraps up our seminar today. And I wanted to thank Varsha, Lauren, and Scott for participating and preparing for today. And then all of you for also participating with the questions. It was wonderful having some active questions that we were able to address live. So I hope the information was helpful, and it will help you as the months come, and we don't know what to expect, but we'll be prepared. Thank you so much.
Yeah,
Great. Thank you, Sita.